All right. So this is the last but one tutorial on 2016 booklet, Krok 2 2016 booklet. So let's quickly go through them. A week ago, a 65-year-old patient suffered an acute MI, myocardial infarction. His general condition deteriorated. He complains of dyspnea at rest. Dyspnea at rest. Okay. Pronounced weakness. There is edema of the lower extremities. Ascites is present. Her heart borders are extended. Paradoxical pause is observed 2 centimeters from the apex beat to the left. What is the most likely diagnosis? What is the most likely diagnosis? So again, they've made an understanding that this person is having what? A case or is suffering from an acute myocardial infarction. And again, you understand what myocardial infarction is all about. When the heart muscles, to be specific, the ventricles, because that's where the pumping really is. When these ventricles are devoid of, of blood or oxygen, let me put it that way, because the blood carries oxygen. So when there is inadequate supply, the place undergo what? Necrosis. And in the heart, we call it what? Myocardial infarction. Myocardial infarction. And again, we've established that anytime we have edema, one of the organs that will be affected or we need to look out for is what? Is the heart. So obviously, we are having a problem with the heart, for which we are developing what? The edema is developing. Ascites is present. Now, there is a clue here to help us with our diagnosis. So over here, they say what the heart borders are extended. What it means is that the heart borders are not actually at the place they normally used to be. They are not at the normal place they had to be. So they have been what? Extended, which could mean that either the heart is kind of inflamed, either there's what? Hypertrophy, or there's something else going on in the heart for which the borders are extended. And they're telling you that paradoxical pause is even what? Observed 2 centimeters from the apex beat to the left. So what are we looking at for? And it is worth knowing that people suffering from myocardial infarction, about majority of them, maybe about 10%, percentage right, 10% of them end up developing what we call cardiac aneurysm. Cardiac aneurysm, whereby there's more of like dilatation, okay, of the heart, dilatation or enlargement. Because why? The heart is not able to pump quite well. So everything begins to enlarge. And so therefore, over here, we could be looking at a problem with what? With acute cardiac aneurysm. Acute cardiac aneurysm, which is also a risk factor for heart failure. All right. A 60-year-old patient complains of nearly permanent sensation of heaviness and fullness in the epigastrium. Okay. It increases after eating. This thing increases after eating. There's foul smelling, eructation, occasional vomiting with food consumed 1 to 2 days ago. Again, Fifi comes to my mind anytime I remember this question. There's what? Weight loss. 12 years, he was found to have an ulcer of the pyloric channel. And again, one of the problems we can find is that there could be what? There could be what? Stenosis. And the person was given what? Ranitidine. Guys, what complication has developed? What complication? Apart from the 3 complications most of you know, which is the perforation, penetration, hemorrhage, one thing that can happen in ulcer is the fact that there can be development of what? Of stenosis. Development of what? Stenosis. And again, the fact that the person vomits 1 to 2 day food ago should tell you that the food are not entering into the duodenum or into the distal part of the intestine. And that is why over here, you are looking at what? At pyloric stenosis. Pyloric stenosis. So your answer is C. Someone's mic is on. Cynthia.
What's
Your
that?
mic is on. Kindly mute your microphone.
You mean what is this?
You have to mute Dr. Cynthia.
Yeah, we following now. I will because she said, I'm not using my ear. She told me that it's because she loves me. That's why she's doing it. So that just.
All right, so here, pyloric stenosis will be more ideal. And in some question, they will say we're having what? A projectile sort of what? Vomiting. A 5-year-old child has body temperature raised up to febrile numbers, suffers from inertness, weakness. Examination revealed hemorrhage on the skin of the limbs and the torso. Enlargement of the cervical and the axillary lymph nodes can be detected. The liver is 4 centimeters below the costal arc. Spleen is 6 centimeters below the costal arc. Blood 2.3. Hemoglobin 60. Platelet 40. Leukocyte 32. Eosinophils 1. Bound neutrophils 1. Segmented 12. Lymphocyte 46. Blast 40%. Duke's bleeding time 9. What examination are you going to look out for? What examination are you going to be looking out for? So first of all, what is your diagnosis in this question? Who can tell me? What is your diagnosis? What are you looking out for? Or what are your differentials?
Hemophilia. Acute leukemia.
Yes. Leukemia. Why? Blast. I say, look at the blast. 40% is too much. Yes, I know they've brought some bleeding time here, which might be suggestive of a case of clotting problems and things like that. But look at the blast, 40%. But don't forget, platelet is what? It's 40. So definitely the bleeding time too might be affected. Platelet is quite low, 40. We said platelet to be around 140 to about 400 in some books. So please, so over here, we are looking at a problem with what? Leukemia. And of course, if you're looking at the problem with leukemia, what are you going to do? Of course, we are normally we'll be thinking of using what? Doing a biopsy because we're looking for what? For, how do you call it? A leukemia, isn't it? But lymph biopsy is different from actually checking into the bone marrow or whatever it is where the cells are being what? Generated from. Okay, so for us to check the bone marrow, because that is where blood cells generate from. So for us to do that, we have to use a process called what? Myelography or a myelogram. We have to do a myelogram. And that's over here, you are looking at B as your answer, a myelogram or a myelography. A child from pregnancy was born in a term labor and has a body weight of 4,000 grams. Length of this. When born, he was non-responsive to examination. Again, we've done this thing before. Non-responsive to examination. Diagnosis is diffuse. Heart rate is 80. What resuscitation measure should be taken? Again, all that we normally do is what? It's our A, B, C. A, B, C. Now, when we say resuscitation, I've explained it before. You are trying to correct a physiological what? Disorder. A physiological what? Disorder. You're trying to correct it. So, but however, they think that this person was, when born, he was non-responsive to examination, which means that postnatal check was absent. I've said it before. Postnatal check was absent. And so therefore, for us to resuscitate this person, don't just go straight into what? Into intubation. No. Over here, we are going to do what? An artificial lung ventilation. Because they thought that the person was non-responsive to examination. That means postnatal check was actually absent. That's what they mean. Postnatal check was absent. So first of all, let us do what? An artificial lung ventilation, but of course with a mask, and that's over here. Your answer is E. We've tagged just like 4 times, if I'm correct, but a lot of times. 15-year-old teenager has undergone a medical examination in the military recruitment center. The following was revealed: interval systolic murmur at the cardiac apex, ascent of the second heart sound over the pulmonary artery, tachycardia. What additional examination? Guys, what are the 2 main examinations we do for people with a heart pathology?
Echocardiography and electrocardiography.
Exactly. So over here, what is your answer? Of course, your answer is what? Is echocardiography. Echocardiography. A 64-year-old patient has been hospitalized with complaints of a progressive jaundice that developed over 3 weeks ago without pain syndrome, along with general weakness, loss of appetite, temperature 36, heart rate 78, abdomen is soft and painless, peritoneum irritation are not detected. Palpation, however, reveals what? An enlarged, dense gallbladder. What disease can you be looking at for? What disease? Don't forget, they've told you that this jaundice is having no pain syndrome. And that is why over here, and look at the temperature too, 36.8. That is quite okay. So this helps you to rule out any case of what? Of infection or any inflammatory process. This helps you to remove any inflammatory process. And again, peritoneal irritation is absent, meaning no sign of peritonitis is present. That means infection too is not there. So all of these things will help you to rule out any sort of infection. And having said that, what we are thinking now is what? Is a cancer of the pancreatic head or the head of the pancreas. That is what we are going to be looking at. Cancer of the pancreas head. Cancer of the pancreas head. So here we are looking at what? At A as our answer. A as our answer. This is not duodenum. This is not an ulcer. It's not an ulcer. So definitely your answer is A. Your answer is A. A 6-year-old girl attended a general practitioner with her mother. Child complains of burning pain and itching in her external genitalia. Girl was taking antibiotics the day before due to her hair suffering from acute bronchitis. On examination, the external genitalia are swollen, hyperemic, white deposit accumulated in the folds. White accumulated in the fold. Again, I've given you guys the differential diagnosis for all these bacteria, vaginosis, trichomoniasis, candida, and a whole lot of things. I've given you guys all of them that you know, that you need to know. But of course, over here, what are you thinking about as your answer? Who can tell me? White deposit accumulated in the fold. What comes to mind?
Candida.
Exactly. That is what? White. Most people call it white. So this is what? This is A. This is A. If you want to know the differential diagnosis, please do well to watch the videos on the basis, I think, obs and gynae. All right. A patient with autopyosis is in sharply deteriorating condition. He developed headache, vomiting, febrile temperature, general hyperesthesia, meningeal symptoms, and stagnant optic discs are observed. Meningeal symptoms. Again, you should know your differentials for what? Meningeal symptoms. Now they are saying there's no focal symptoms. Liquor is turbid. Blood pressure is high. Albuminocytological dissociation occurs with neutrophils. With neutrophils. What disease can you suspect? What is your answer, guys?
Encephalitis.
Come again?
Secondary purulent meningitis.
Yes. This is not meningitis. This is not meningoencephalitis. No. This is what? Secondary. Why? Because autopyrosis. Yes, that is the primary disease. But as a result of this disease, it is now migrating into the head. Okay, or into the meninges, if I should put it that way. And that is why we are having what? This present. And again, the locus should also tell you more about it. Neutrophil. So bacteria infection, of course. Bacteria infection. But of course, if they were to be what? RBCs or blood inside, you could be thinking of what? A subarachnoid hemorrhage. You could be thinking of a subarachnoid hemorrhage. So of course, over here, your answer should be A. Should be A. In meningosemia, sometimes you might see skin rashes and all of those things appearing on the baby or on the child. All right. 25-year-old patient is not married and has sexual relations with several partners. Alphonse, stop going to sue me. During the last 3 months, he noticed a small amount of mucocerial secretions produced from the urethra. Okay. So, sexual partners, now we're having what? Infections. Periodically, there's what? There's a periodical itching and burning pain in the urethra. 2 months ago, pain in the knee. Someone gave me some shortcut or something. Pain in the knee. This is joint. Pain in the knee joint developed. Possibility of trauma or exposure to cold is denied by the patient. During the last week, eye discomfort is noted. Lacrimation and itching. What provisional diagnosis can be suggested? I think Kalila.
Reactive arthritis.
Exactly. Somebody was saying some shortcut. Me still, it's not even in my head still. Something eye, something.
Yeah.
No work and no
Can't
speak.
pee, can't see, can't bend my knee.
Okay, can't pay, can't see, can't pee, can't
Can't see, can't pee, can't climb a tree.
Or can't bend my knee anyway.
Can't bend your knee.
So please, that is what reactive what? Arthritis. Reactive arthritis. But basically put, anytime you see a rheumatoid disease process or a rheumatology process or disease coming with UTIs, please consider these things or consider reactive arthritis. All right. A 19-year-old patient complains of severe pain in the axillary crease. Condition onset was a week ago after her swimming in a cold river and explanation. The next day, painful boil appeared that was becoming larger every day and become a plum-sized tumor. Upon examination, nodular conical growth joined together are detected. The skin covering them is bluish red. Some nodules have fistulous openings, producing thick, purulent masses. Temperature 38, general malaise or weakness. The most likely diagnosis is what? Again,
Hydradenitis.
exactly.
Hydradenitis.
Thank you. We have done these things, guys. We have done these things. See how people are enjoying. We've done them.
No,
We've done them.
you must be special if you're African and you've never had hydradenitis before.
So over here, we're looking at what? At C as our answer. C as our answer. All right.
Yo, but explain the hydradenitis.
Okay, so basically, this is just what? How do I put it? It's simply an infection. Okay, that is occurring. That is leading to what? How do you call it? How do I put it safe? Lump formation and things like that, like it is in our case. Now, when we are referring to something referring to boil, you know, a single boil is called a furuncle, isn't it? Double or many boils is the what? Is the carbuncle. Is the carbuncle. But this is not talking about boil. This is not talking about carbuncles. However, this is talking about what? An inflammatory what? Process. An inflammatory process that is occurring on the skin that is looking like a boil. Do you understand me? That is looking like a boil, and hence the name hidradenitis. And actually, the real name is hidradenitis suppurative, or a suppurative hidradenitis. Why? Because they end up producing a lot of what? Pus formation. Or they help secreting all these pus and stuff like that. Even though boil can also produce those kind of things, but this is not a typical boil. This is not a typical boil. However, they describe it as what? A boiled appearance. A boil appearance, but it is not a boil. Hope you are clear now. So this is C. This is C. All right. Annual report of an inpatient ward presents data about the number of patient days and the number of patients who have undergone treatment within a year. What work indicator of the inpatient ward can be calculated based on these data? Based on these data. In other words, if you want to know the total number of people that was that were admitted in the hospital for the whole year, okay, that's what they're asking for. Data to know what? The number of days and the number of patients. So this deals with what? Inpatient treatment, or people who have been what? Admitted. And how do you calculate, how do you estimate the total number of people? So of course, you need to do what? Calculate the average duration of those people that were admitted. The average duration. And of course, anytime you go to the ward, there's a chart or there's a sheet. Okay, time of admission is there. Maybe 10:30. Discharge, they'll write it there. Maybe the following day, 5:30, something like that. It's always written on the chart. And even now that we are using the computer, in Ghana, we're using the computerized system. We also indicate it in our chart. And actually, in every hospital, if you go, anything that you want, even as a doctor, the time you look at the patient, you have to indicate the time. Very, very important. So if we want to estimate the people that have been there in that hospital, just calculate the average duration. All right. So your answer yes, what is D? ECG revealed the following. In a 10-year-old child, the sharp acceleration of the heart rate. Sharp acceleration of the heart rate. Okay. 240. P waves overlaps with the T wave. What means that we're having what? An ectopic P wave. We're having an ectopic P wave. When we say ectopic P wave, we are simply referring to what? We are simply referring to an irregular heart rhythm due to a premature heartbeat. Now they said what? And deforms it. Moderate lengthening of the PQ interval. But look at it. QRS complex is without changes. Again, so now let's do a little bit of revision. What does P wave contribute to, or deals with what? Atrial contraction. Again, P wave with atrial contraction. T wave deals with what? Relaxation. Yes. QRS deals with what? Ventricles. Deals with ventricles. Now they are saying that we're having an ectopic P wave. In other words, a P wave that's overlapping with the T wave. It doesn't mean that there's a problem with the T wave. It's the P that is overlapping with the T wave. And QRS is actually what? Not without any what? Changes. So what pathology are you looking at for? Definitely, we are looking at the problem with what? With a paroxysmal what? Atrial tachycardia. Paroxysmal atrial tachycardia. Again, the word sharp could mean sudden. Sudden acceleration, sudden. The word sudden, in medicine, we can call it what? Paroxysmal. And again, the heart rate is always more than 150 to about 240. So please, all of these to take note. So answer is B. A 54-year-old patient complains of weakness, jaundice, itchiness. Disease onset was 1.5 months ago. Fever is 39. Appeared at first. Progressive jaundice developed 2 weeks later. On hospitalization, jaundice was severely progressed. Liver cannot be palpated. Gallbladder is enlarged and painless. Enlarged and painless. Guys, we've solved a similar question. What diagnosis are you looking at for? Gallbladder is enlarged and painless. What comes to your mind?
Hepatocellular jaundice.
Come again?
I'm looking at hepatocellular jaundice.
Liver is not palpated. It's okay. No. Let's take note. I'm not referring to the type of jaundice. I'm referring to the real disease. Forget about the jaundice. I'm not referring to jaundice. I'm referring to the real disease.
Cholecystitis.
Okay. But it is painless.
Or it could be choledocholithiasis.
So let's look at somewhere around the pancreas. Guys. Somewhere around the pancreas. Somewhere around the pancreas.
Bile duct.
And I'm telling you, the distal portions that you should be looking at. Okay, that's what we should be looking at. Now, if there's no temperature, maybe you could think of what? The cancer. So all of these things, let it be in your head. Now, bilirubin is 190. And that is what? For direct, that's conjugated bilirubin. Stool is colorless. And again, we know all of these things. Now, we know pre-hepatic type of jaundice, hepatic jaundice, and post-hepatic type of what? Jaundice. We've described all of these things. And of course, over here, we are looking at what? A mechanical type of what? Jaundice. Because the problem is not with the liver. The problem is not before the liver. The problem is after the liver. Exactly. So this one, we took our time and we went through them. So please, do well to watch the videos. I beg you. This will be on therapy. So here, you are looking at what? Mechanical jaundice. Mechanical jaundice. 22-year-old patient complains of 8-month delay of menstruation. Anamnesis, menarche since the age of 12.5 years. Now, since the age of 18, menstruations are irregular. So that means that the person had her menarche on this date, this year. Then for the past 8 months, they've been delayed. However, since 18 years of age, she's been having irregular menstruation. That's just it. However, there's no pregnancy. Normally, when there's delay of menstruation, you know you are thinking of what? Pregnancy. And that's why you do what? 2 tests. What test will you do? 2 tests you do. Quick.
The beta HCG.
Good. And what? Ultrasound, guys. Ultrasound. Great. Now, mammary glands have normal development. When the nipples are pressed, milk drops are discharged. On gynecological examination, moderate uterus hypoplasia. On hormonal examination, prolactin exceeds the norm. Look at it. On the CT of the celatusica. Before I go on, what sits inside the celatusica?
The pituitary gland.
The pituitary gland. Very good. Now, they say it's occupying a lesion of 4 millimeters in diameter was detected. What is your diagnosis? Of course, you are thinking of what? Of a pituitary tumor, no doubt. A pituitary tumor. For now, by now you should know what Sheehan's, Leventhal, and all these things are. You should know them. Let's not waste time on it. All right. So this is what? Pituitary tumor. A 2-year-old child is in a satisfactory condition, but periodically present with a moderate proteinuria, microhematuria. Result, the left kidney is undetectable. The right one is enlarged. No signs of double pilocalicial system. What study is required to specify the diagnosis? And over here, is Eugenia around? Eugenia is not around. Okay. But this is Eugenia's favorite question. And of course, we deliberated on it even in the last presentation. So over here, you are looking at what? We are looking at excretory urography. We talked at length over it. We talked at length over it. Some of you contributed. I remember Lawrence contributed. Everybody contributed on some of these things. So please don't get confused. So basically, you are checking for what? Obstruction in the upper urinary what? Tract. Obstruction in the upper urinary tract. In the upper urinary tract. So therefore, over here, we are looking more of what? Of C. That is what? Excretory urography. A 13-year-old girl complains of fatigability, frequent headaches, cardialgia, that is heart pain. 8 years ago, she had a case of pyelonephritis. Dummy, pyelonephritis. Urine analysis periodically revealed leukocyturia. Child has undergone no further treatment. Examination BP is 150/100. Ultrasound revealed a reduction of the right kidney. Reduction of the right kidney. What process is leading in arterial hypertension pathogenesis in this case? What is the leading mechanism? Now, already they made us understand that this person was having what? An acute pyelonephritis, or have a case of what? Not really acute, but so now 8 years, this is chronic, isn't it? So we're having a case of what? Pyelonephritis, which is just a bacterial infection of the parenchyma, okay, of the tissues in the kidney. Okay, so when these tissues for 8 good years are inflamed, what can it lead to? A chronic process can always lead to what? To scarring. It can always lead to what? To scarring. To scarring. And that is a potential a risk factor for having what? A damaged what? Kidney. It's a risk factor for having what? A damaged what? Kidney. And they're saying that this person is having what? A reduced right kidney. That means that the thing is either it is shrinking or whatever it is small. It is small. So now this is the case. Now, if it is small, what it means is that renal functions, one way or the other, are sort of impaired. Renal functions have been what? Impaired. So what is then the mechanism of the development of this BP? That's what they're asking us. What is the mechanism of development? And as of now, you should know the mechanism of what? The RAS system. You should know the mechanism of the RAS system. The RAS system. Renin-angiotensin-aldosterone system. You should know the meaning of this. So what happens is that when the kidney is sensing or is not able to sense the right amount of, salt or sodium, let me put it that way, sodium, it begins to secrete or it begins to activate the, the gesta glomerular apparatus or the gesta glomerulus. And when it activates the gesta glomerulus, this glomerulus begins to secrete what we call what? Renin. Okay. This secrete what we call what? The renin. And when the renin, what am I saying? So first of all, when there's a reduced function in the kidney, what it means is that blood is not flowing inside the kidney. So the macula densa, is able to detect the concentration of sodium. So when sodium is not being felt or we are not seeing sodium is coming around, it means that sodium is not in the system. So the body in its own way begins to have what we call a vasoconstriction. Okay. When there's vasoconstriction, it then begins to activate this gesta glomerulus because of the macula densa, gesta glomerulus. Then renin is produced. This renin will now go on to activate what we call angiotensinogen. This angiotensinogen will now convert angiotensin 1 to angiotensin 2. And this 2 will now go on to activate the adrenal system. But of course, we're talking about the outside layer whereby aldosterone will now be released. And when aldosterone is not released, what happens? Of course, salt will begin to come to play. And when salt comes to play, that is why, salt is for absorption of or salt retains water, or it retains fluid. And that is how come this BP will now be happening. I know I've said so many things, so take your time and rewind, or after presentation, just remind me and I'll bring it back. So this is what? Renin-angiotensin system. All right. So after that, if you are lost, just bring me back, okay? A 26-year-old patient with affective bipolar disorder has developed a condition manifested by mood improvement, behavioral and sexual hyperactivity, verbosity, active body language, reduced need for sleep, reduced need. Okay, which of the following drugs are most efficient in this case? Which of the following are most efficient in this case? So this person having what? Problem with what? Behavioral and sexual hyperactivity, verbosity, active body language, and all those things. So that means this person is gradually developing into what? Some psychiatric what? Disorder or psychiatric what? Problem. And of course, you need to give the person what? A neuroleptic drug. Neuroleptic drug. Neuroleptic drug. And of course, these neuroleptic drugs should have a sedative effect so that the person can be able to sleep very well. And that's what over here you will be looking at what? At a neuroleptic because of the presence of what? A psychiatric, psychosis, if I should put it that way. So you give what? A as our answer. A as our answer. This is not antidepressant. This is not in depression. So don't go and say antidepressant just because you have seen mood. Don't forget that the person has developed a condition manifested by what? Mood improvement. So for the mood there, it's improved. But other things are not good. That's why we are going to go for what? A neuroleptic, not antidepressant. A 32-year-old man complains of pain in the chest. On the left, dyspnea, temperature rise up to 38 degrees, slight cough. Disease onset was weeks ago after overexposure to cold. Overexposure to cold. He had suffered from what? He has suffered from Broncho Adenitis. Please, this is one word. Broncho Adenitis in his childhood. So what then is a Broncho Adenitis? Broncho Adenitis is an inflammatory process in the intrathoracic lymph nodes that lie next to the bronchi or the large bronchi and the trachea. And usually it comes from tuberculosis, or it originates from tuberculosis. It originates from tuberculosis, but it can also originate from bronchitis. It can also originate from bronchitis, but normally it comes from what? From TB or tuberculosis. That's what bronchoadenitis. Now, the affected side lacks during breathing. Percussion reveals dull sound with oblique margin in the lower left lung where breathing is absent. The right heart border is displaced. Mantox, again, anytime you hear of Mantox, what comes to mind? Test for tuberculosis comes to mind. Mantox test was done. What diagnosis are you looking at for? Of course, even if you don't know that this bronchoadenitis has to do in a way with tuberculosis, they should tell you that we're having what? A tuberculous pleurisy. A tuberculous pleurisy. Tuberculous pleurisy. So your answer here is what? Is C. Is C. Is C. All right. Pleural cavity. So don't get confused with pleurisy. All right. An emergency doctor has diagnosed a 32-year-old woman with generalized convulsive status epilepticus. The deterioration in the patient condition is caused by the sudden gap in the epilepsy treatment. So this person has what? Defaulted in medication. So what should be your tactics. Definitely, this you need what?
Intensive care.
Hospitalization. Yeah, intensive care. So the answer is what? Is A. Is A. A 19-year-old patient complains of dyspnea during physical exertion. He often has bronchitis and pneumonia. Cardiac murmur has been observed since his childhood. On auscultation, there is splitting. I think this is one of the reasons why we said we will talk about murmurs, isn't it? And the heart pathology. But I know you guys can remember this question. Especially Christopher, you can remember this question. So there's splitting of the second heart sound over the pulmonary what? Artery. Systolic murmur in the third intercostal space near the left sternum margin. ECG test shows right bundle branch block. What is the provisional diagnosis? And again, we had a lot of debate on this question. But of course, one thing that can help us with our answer is the fact that we're having what? A splitting second heart sound. So therefore, over here, your answer is what? Juma, what's your answer? Juma. Okay, Christopher, what's your answer?
Interatrial.
Exactly. Interatrial septum defect. So your answer is what? Is D. Again, I'll look for another time and then we'll talk about some of these things in details. A 75-year-old male patient complains of slight pain in the right iliac region. So right iliac region, you know what is there. You are thinking of what? The cecum, you are thinking of what? The pancreas. Sorry, the appendix. The appendix. So either the cecum or what? The appendix. You know, it happens when you talk too much. I know Ella is saying I'm talking too much. Pain in the right iliac region. The abdominal pain arose 6 days ago and was accompanied by nausea. Surgical examination revealed a moist tank. Pulse 76, BP 130/80. Abdomen soft, slightly painful in the right iliac region on deep palpation. So again, you are thinking of something over there. Now they're saying that peritoneal irritation were doubtful, meaning there's no sign of what? Peritonitis. RBC, 4 hemoglobin, WBC, stab neutrophils, segmentonuclear, lymphocyte, monocyte. Guys, what are you looking at for? First of all, what's the diagnosis? Tell me. Diagnosis what? Don't tell me answer here. What is the diagnosis?
Appendicitis.
Exactly. Appendicitis. You're looking at appendicitis. And so therefore, your answer what? Emergency operation for acute appendicitis. As simple as A, B, C, D. All right. An 8-year-old boy has 2-year history of blotchy, itchy rash appearing after eating fruit. That's more or less like what? Allergy. The first eruption occurred at the age of 6 months after the introduction of juice to the baby's diet. Okay. Father has a history, you see, of asthma. Mother, that of what? Allergic rhinitis. So definitely, what is your diagnosis? Of course, you are thinking of what? I say acute. Atopic dermatitis. Atopic dermatitis. All right. 25-year-old patient has been admitted to the hospital with the following problems: weakness, sweating, itchiness, weight loss, enlarged submandibular, cervical, axillary, inguinal lymph node. Guys, forget about all the grammar they are saying. This is your clue. Lymph nodes revealed a giant Berezovsky-Reed-Sternberg cells. Guys, what comes to mind? Reed-Sternberg cells.
Hodgkin's.
You are thinking of what? Hodgkin's disease or Hodgkin's lymphoma. Another name for Hodgkin's lymphoma is what? Lymphogranulomatosis.
Or
Granulomatosis. So your answer is B. No to waste about. The other things are just to add up. That's all. All right. An 8-year-old child was hospitalized for fever of this, innate, moderate headache, vomiting, meningeal symptoms. Anytime I see a question of meningeal symptoms, I get so excited. Lumbar puncture was performed. The obtained fluid had raised opening pressure, that means increased pressure. It was transparent with cell count of 450 cells, mainly lymphocyte. No wonder it is what? Transparent. That means no pus formation, no neutrophils formation. Cells are there. What is the causative agent? So first of all, lymphocyte tells you what kind of agent. Is it bacteria, virus, or fungi, or whatever? What is it? Virus. So obviously, your answer is what? It's enterovirus. Enterovirus. So always analyze your CSF. If it was blood, we are thinking of what? Arachnoid what? Hemorrhage. Aha. Okay, this is good. 25-year-old patient during self-examination detected a tumor. Tumor is there in the upper external quadrant of the right mammary gland. It's painless, dense, mobile, 2 centimeters. It detected no changes in the peripheral lymph node. Ultrasound in the upper external quadrant, the right mammary glands. There is a space occupying lesion, increased echogenicity. What are you looking at for? No changes in peripheral lymph node, painless, dense. What comes to mind?
It's cancer.
I'm coming to beat somebody.
Which cancer?
This is not cancer. We've explained it over and over. We are dealing with adenoma. Uche, we talk about this. They help you with it. Please go over it again.
Uche, the cancer of body something.
But you said hypergenic. You said hypergenic thing. Or hyperechogenic, whatever it's most likely a cancer.
Good. Now
that's
relax.
what you said.
Now, if you realize, I think this is one of the things I was saying we have to go and look for how cancer itself looks like, isn't it? Because something like a stone, I think Eugenia asked me that kind of question some time ago. You remember it, right? So,
I'm so sorry.
So that kind of thing we have to look out for. But please take your time and look at the question carefully. We have talked about this like a dozen times. So please take your time. So if you see this question again, remember that we argued. So the answer is what? A C, fibrous adenoma. 2 weeks after labor, a parturient woman developed breast pain, being observed for 3 days. Pain revealed temperature rise. The temperature rise. So that means there's infection, one way or the other. Chills, weakness, hyperemia, enlargement, pain, deformity. Again, all of these are all signs of what? Infection. Now, on palpation, infiltrate was found. Guys, what is your diagnosis? Let me know. Continue.
Infiltrative
purulent. Of course. Infiltrative purulent mastitis. Answer is C. Answer is T. 48-year-old woman has been suffering from chronic pancreatitis for the last 7 years. Lately, she has been noticing an increase in daily visits with foul smell, abdominal distension, gargling. Patients complaints of diarrhea, weakness, fatigability, loss of appetite, loss of weight. What syndrome are you suspecting, guys? What syndrome are you suspecting? Now, if someone is having what? A case of chronic pancreatitis, first of all, you ask yourself, what will a complication of, because definitely we're talking about complication of what? Pancreatitis. Chronic pancreatitis. And one of the complications is that there will be what? Indigestion. There will be what? Indigestion. What I mean by indigestion is that there is going to be what? Inadequate supply of what? enzymes to work on the food that is taken in. That this person having what? Weight loss. He's not even having appetite for food even. So what syndrome are we looking at for? We are looking at for what? Malabsorption. Malabsorption. Because food is not being digested. Food is not being digested by the enzymes due to the chronic condition of the pancreas. And that is why the feces comes out smelling. That could also mean that there are some fats that are inside or things that are inside that are not what? That were not emulsified. So over here, we are looking at what? Malabsorption. Malabsorption. So your answer here is what? Is B. B.
Why maldigestion since it wasn't digested?
Yes. So over here, we're looking at for what? A syndrome. Syndrome. Yes, there's maldigestion because there is indigestion present. But the syndrome, whereby though there is indigestion because of what? Also, there's no, food to act upon them. But basically, if there's indigestion, that means the food is also not absorbed, isn't it? Because food has to be acted upon to be absorbed. Otherwise, they can't be absorbed. Otherwise, your body will not get the right nutrients that it needs. So all the symptoms that come to play as a result of the maldigestion, we call it malabsorption syndrome. Malabsorption syndrome. Malabsorption. But of course, there's indigestion. But the best answer is what? Malabsorption syndrome. So your answer here is what? Is B. 37-year-old man suffers from attacks of unconsciousness, dyspnea, during physical exertion, periodical sensation of the heart disorder. Father of the patient died at the age of 45. Objectively, heart rate is 90. BP 140/90. On the ultrasound, ejection fraction is 14. What is happening to me? Ejection fraction is 49%. Significant myocardial thickening of the left ventricle and the interventricular septum. What drug should be prescribed for the treatment? What drug should be prescribed for the treatment? So over here, you will need what? A beta blocker. You will need a beta blocker. Yes, indeed, we are having a BP of 140/90, but this is what? Mild hypertension. This is not a severe hypertension. It's mild hypertension. So no need to start looking for a furosemide or captopril or ACE inhibitors or things like that. No. All you need is a beta blocker. Beta blocker. These help to treat high blood pressure, to treat angina, and to treat heart failure. But again, all the options that you are seeing here, apart from bisoprolol, the rest are all what? A diuretic a diuretic sort of drugs. But over here, we want the heart to work properly. We want the heart to prevent heart failure and things like that. So therefore, we give what? Bisoprolol.
And Dr. Baha, B is an ACE inhibitor, isn't it?
Yeah, come again? Yeah. Like captopril. That's what I was meant. Captopril comes to my mind.
Or ramipril.
Exactly. All of these things are all ACE inhibitors. All right. During a regular checkups of a 50-year-old woman, a tumor was detected in the mammary gland. The tumor is 5 centimeters in diameter. Dense, guys, look, without clear margins. Uche, without clear margins, the skin over the tumor resembles a lemon, some people could say lemon peel. Nipple is inverted. Lymph nodes can be palpated. What diagnosis are you looking at for? This goes
breast
Uche.
cancer.
Exactly. Uche, breast cancer. So this is your cancer.
Breast cancer, sir.
Exactly. Now you have seen a little bit of difference, right?
It's not my cancer, sir.
Okay, sorry, I don't mean your cancer, but I mean your favorite diagnosis. All right, so answer is D. All right. A 20-year-old, I've seen some questions, hands being raised. We'll come to them. A 20-year-old woman complains of sensation of air shortage. Sensation of air shortage. Lingering dull pain in the heart area. Irritability. General condition is satisfactory. General condition is satisfactory. Okay. So on general examination, condition is okay. Heart rate is liability. BP 130/60, which is actually okay. ECG reveals disruption of ray polarization processes. That's more or less like what? The T waves. The patient is diagnosed, diagnosed with what? Somatoform. Up until now, you should know what a somatoform is. You should know what a somatoform is. So how should we treat this patient? Who can tell me?
Psychiatric department.
Why psychiatric department? Somatoform means that...
Sorry.
Outpatient.
Sorry.
Yes.
Sorry.
Outpatient. This person is not mad, though. Please, don't say the person is mad. No.
Sorry. No,
Uh-huh.
I think what my mind was going to was kind of psychiatric disorder thinking.
But this is what?
Sorry.
Somatoform. Good.
Yeah.
Somatoform dysfunction. And so, therefore, this patient should be treated outpatiently or outpatient treatment. That is it. So, OPD. So, the answer is what? Is A.